Hello, my name is Dr. James McKenzie. I am a chiropractor that is board certified in neurology. Today I'm going to talk about PTSD. So PTSD and acute stress-related disorders are triggered by traumatic or stressful events, including being a witness or being involved in a violent crime or accident, military combat, being kidnapped, being involved in a natural disaster, or being diagnosed with a life-threatening illness. So most prevalent among males. So males are way more likely than females to end up with this. Risk factors include living alone, poor social support, low socioeconomic status, but most important factors are exposure to actual trauma. Biologically, people that are closely related, if they have a history of depression, this increases the risk of developing PTSD. Other predisposing factors are childhood trauma or personality disorders, especially paranoid and dependent types, and then recent excessive alcohol use. So we see with lots and lots of mental health issues, alcohol being abused, and sometimes other kinds of drugs. So what's actually happening in the brain? Well, there's a lot happening in the brain if it's PTSD. Disturbance of the hypothalamic pituitary adrenal gut axis. So what we're saying here is that the area of your brain that controls appetite, thirst, sex drive, sleep-wake cycles, body temperature, all that stuff isn't communicating very well to the body, and this also affects the gut. So your whole hormone system is out of kilter. We see especially increased cortisol, and we have increased other stress hormones, especially norepinephrine, and this drives an abnormal stress response. So whereas somebody else, it would take way more stimulation to have the same stress response. Patients with PTSD, it's just a little bit of stimulus and they have a huge response. So they overreact to very low levels of stimuli. And they have prolonged increase in corticotropin-releasing hormone, which blunts the adrenocorticotropin hormone. And so we see also that we have hippocampal atrophy. What's the hippocampus? That's the part of your brain that allows you to have good short-term memory. So we see this area start to atrophy. This is really important. I mean, if a patient has PTSD, they should be getting the right kind of brain rehab to try to maximize these areas of the brain so that they don't atrophy. And if they've already started atrophying, whatever you can do to slow that down and increase the function of those areas, it makes sense to do that. They actually have increased dopamine levels. So lots of conditions don't have enough dopamine, but PTSD actually has too much dopamine. And so we don't want to give them more dopamine. That would be a bad idea. Other conditions that also have too much dopamine include schizophrenia and sometimes bipolar as well. We already said that they have increased norepinephrine levels. They have decreased serotonin. So we either want to give them a medication that's going to recycle it, or we want to help their brain actually make its own serotonin, which I think makes more sense. They have decreased GABA, and there's actually supplements that can help change that so that the brain is making more of its own GABA, but this makes them have more anxiety. They also have increased glutamate. So basically, glutamate is an excitatory neurotransmitter that we don't want it to be too excitatory. What's happening for patients with PTSD is that the glutamate is working really hard, and it's driving microglial activation, which stimulates more glutamate release, which drives more of that. And this basically causes neural degeneration by overactivity of certain parts of the brain. And anyway, in the cortex, the areas that we see especially affected are the prefrontal cortex, the anterior cingulate, and the medial prefrontal. So literally certain areas of the brain shrink, and then other areas are just not activated enough. So we can figure all this stuff out with our exam, and because we can actually start localizing these areas of the brain and actually targeting them. So some diagnostic criteria: exposure to actual or threatened death, serious injury, or sexual violence, and one plus of the following. So directly experiencing traumatic event, witnessing in person the event as it occurs, or learning that traumatic event occurred to a close one or relative. Repeated or extreme exposure to details of traumatic events. So like if, for example, you get to show up and be the first responder, it's going to have more of an effect on you because you're going to visually see it when it actually happens, and so that can give a lot of trauma. Dissociative flashbacks in which a person feels or acts as if the trauma is recurring. Negative alterations in condition and mood beginning or worsening in the traumatic event. So something called dissociative amnesia is a quality that we see with PTSD. We also have to consider other things. So higher levels of social, occupational, and physical disability, poor social and family relationships, absenteeism from work, lower income, delay in symptoms, can be as short as 1 week or as long as 3 years. So it's weird because somebody can have something happen to them and then 3 years later it really gets them. But symptoms can fluctuate over time. But anyway, these are some of the things that people with PTSD deal with. So it affects their work, it affects their relationships, it affects their whole life, because if the brain doesn't work as well as it could, then you're not going to interact with people the way you would otherwise. We see better prognosis if there's a rapid onset of symptoms. So in other words, if the symptoms start in 1 week rather than 3 years, you have a better outcome. If the duration is shorter, like less than 6 months, good pre-morbid functioning. So in other words, if you're pretty healthy to start with, that is a good predictor of outcome. Strong social support, and no psychiatric issues or other kinds of medical issues or substance abuse disorders. If you have those things, then you have a much better outcome for treatment. When we look at PTSD, we have to differentially diagnose from other things that are similar, such as acute stress disorder, adjustment disorder, panic disorder, personality disorder, substance abuse, psychosis, epilepsy, traumatic brain injury, and anxiety, because you can have a certain amount of overlap between these things and as well. They're very similar to PTSD. What we see oftentimes attached to PTSD, 2/3 of them basically have other disorders such as depression, bipolar, anxiety, and substance abuse. That's a lot. So so a lot of patients with PTSD, most of them have other things that are attached to that. In combat veterans, there's a 48% comorbidity with a mild traumatic brain injury. So really, a lot of them have had head injuries, and this just sets up all kinds of problems. There is major neurocognitive association, and we can measure all that and quantify it. And so the standard of care right now is psychotherapy, which is very, very good as far as management goes. The medications also help manage, but a lot of patients are very, very miserable that have PTSD. I mean, they can hardly function. But without rehabbing the brain, this is about as good as it gets. So things that are going to help with symptoms and trying to recycle what the brain doesn't have enough of, etc. And so, how can brain rehab help a patient with PTSD? Well, that's kind of a loaded question because every single patient with PTSD is going to have their very own unique set of findings. What we want to do first is we want to look at the labs and we want to see and make sure that the brain has what it needs so that it can be rehabbed. So if a patient has an underlying infection, or they have a problem methylating, or they have a problem with anemia or blood sugar problems or vitamin D deficiency, or they have certain kinds of hormonal issues or autoimmune disease or things like that, we have to find out because we need to be able to work on those things while we're rehabbing the brain. Otherwise, the brain just doesn't really have a chance to be rehabbed. We have to quantify the severity of PTSD. So, and then we can re-measure that later on. We can do that with CNS vital signs. It gives us the ability to score it and give it a number. Then where our goal is to localize what areas of the brain, based on symptomatology, are the problems occurring, and then we can also look and see what neurotransmitters are probably not working right in the brain, as well as we can actually look and see which areas are underactive or overactive based on quantitative EEG. If an area is underactive, then we know it's obviously not getting enough stimulation. That's an area that we want to stimulate. If an area is overactive, we know that it's getting too much stimulation, and we want to chill that area out. Areas that are underactive or overactive over prolonged periods of time, we know that these areas are degenerating. And so if we want to stop the degenerative process, we have to change that activity in the brain. And we can do that using neurofeedback. And then we also want to make sure we nourish the brain. If people aren't eating good fats and they're not getting what they need for their brain just isn't going to get better. So we want to make sure that it has what it needs. If it's inflamed, we want to make sure we get that inflammation down, etc. Also, we're going to give home exercises to balance out the sides of the brain and to change the firing rates in the brain, so that this helps create more long-term change rather than just coming in and getting it. Basically, your treatments are going to last about an hour and a half at our clinic, but we want to make sure that throughout the week people are constantly stimulating those areas of the brain. And we work with other members of the healthcare profession. If you have PTSD, it's going to be very important that you do have a psychotherapist on your team, and we're willing to work with those guys so that you can have the best outcome. And we also like to do pre and post tests to make sure that we're creating long-term change in your brain, because with brain rehab, we don't want to just create a short-term change. We want to create long-term changes so that you have the best outcome in your quality of life and your brain's ability to function at the highest level possible. So if you're interested in more information, this is our contact information. Feel free to get a hold of our clinic, and we're willing to respond to any questions that you have. Have a great day. Thanks a lot.